So thank you, Jay, for the introduction. And I want to thank all of you again for being here today. I'm hopeful that my talk today will stimulate some discussion about how, taking from Paul's points about some of the gaps in care, how we can start thinking about revolutionizing. Is that the word, Benoit? Am I using that? Revolution? I can't see where Benoit is right now, but a revolution in terms of education in medical psychiatry. So as Jay alluded to, I'm a psychiatrist, but I'm a consultation liaison psychiatrist, and I'll talk about nomenclature and names and how that in itself has been problematic as we're embarking on the Medical Psychiatry Alliance. But I spend most of my time as an orphan. There are a few CL psychiatrists here and a few colleagues who see me and take me into their homes from time to time. And so I spend my time on internal medicine wards. So thank you to the internists who take me into their homes on a time to time. Also a hepatologist, surgeons. And at this interface is where I actually witness the issues of care that Paul's alluded to in terms of gaps of care, access to care, and stigma. One of the most striking personal stories to me is when I was a resident with Susan Abbey, who's here, and setting up an office probably, I think, 3 floors above the hepatology clinic. And I had, many of you know Jenny Heathcote, who's a gastroenterologist, who heard that I was starting on the rotation and walked up my first patient from the clinic before I'd even set up a referral system, who was a patient who was suicidal in the midst of an autoimmune liver disease and a diagnosis. And so said, I heard you're taking patients. I have one for you today. And I was in the middle of a psychotherapy session, a little difficult to navigate, but nonetheless, I think it highlighted the need. What I quickly found, though, that there was challenges for patients to access care, even 3 floors, navigating the system, the stigma of waiting in a waiting room with other patients who they felt they couldn't identify with, although they often shared common conditions. What ended up happening is we integrated into the same floor and started developing a system of care informally. I would say more of a shared care model, with the goal of moving to a more integrated care approach. And I think, those experiences have been quite formative in terms of how I see how we can transform our learners. And we have many residents and students now coming through that have really been surprised by this interface. So I do have a case that I think will highlight and ground some of my discussion. I do think before we look forward, it's important to look back and see where we've come in terms of the historical perspectives. I'll talk about gaps in medical psychiatry training, and my disclosure will be that I will speak about mental health and psychiatry as my experience in some of the literature, but I hope that in the discussion we talk more broadly, and then talk about opportunities, in particular how the MPA can be an excellent vehicle to start addressing these training needs. So here's a case of Joe, and many of you may or may not relate to a patient that you may or may not have seen in the last few months, but he's 54, he has a history of bipolar disorder, obesity, chronic obstructive lung disease, he's got hypertension, he's got problems with alcohol use, and I did not coordinate my slides with Paul, but many of the issues he's talked about have been raised. He reports significant depressive symptoms, anxiety, shortness of breath, chest pain. Unfortunately, he hasn't had psychiatric care for over a year. Okay, and that's not for a lack of referrals. And he last saw his primary care physician 10 months ago, and again, not for a lack of having a primary care physician or an excellent team, but difficulties attending his medical appointment. So here he is in the emergency department. He's being triaged, and so that's the first point of contact. I ask you, obviously as clinicians in the room here, that you probably would look at severity, the risks, in this particular patient, but what are the potential options for this patient in our current system right now? I'd like just shout out for me. Where is this patient going to go? Medicine. There you go. Okay. Go into the medical floor. Okay. All right. And so what about anyone else want to offer another alternative that could potentially be here? Stays in the emergency department and gets discharged. Okay. Stabilized and discharged. Okay. Any other ones? Okay. Right, so ruling out any severe disease, what if this is part of anxiety? What if this is part of a panic disorder? What if this is part of depression? So there are a couple of pathways, but I wonder in those pathways, where does this patient and the family feel in terms of where their care is being delivered, right? I'm fortunate to work in a setting where we do have some integration, but striving for more. And so you aptly said, you're ending up in the medical ward, or you can end up into a psychiatry unit. But I think part of this perpetuates the ongoing silos. And one of the discourses that I have a pet peeve with is the issue of medical clearance, right? What about that whole issue of medical clearance, right? It works both ways, right? So once a patient's in emergency, they're medically cleared, right? And they go to psychiatry. We just heard from Paul that medical clearance is probably a myth given the high comorbidity and longitudinal care. And then they enter the mental health system, and we unfortunately have these issues with access to care for medical care. So we're going to come back to that later on. So this is the aim statement of the MPA here, to teach current and future healthcare professionals how to prevent, diagnose, and treat mental and physical illness in a novel integrated care model. So very broad, overarching theme, but I'll try to distill that down further. So I'm going to talk a bit about the past before we start talking about where we're at and where we're headed to go. So there's a poor French philosopher, René Descartes, who's been plagued with the mind-body split in Cartesian dualism, and where many of this has emerged. In fact, in reading his work, I have to admit I haven't read all his work, but in reading some of his work, in fact, that wasn't the message that he intended. Many of the educators here are well versed in Flexner Report and the integration of modern sciences into kind of early kind of undergraduate training, and much of this is still perpetuated in our current medical training system, although we're going to hear about innovations later today. And then, I don't know, many of you know who George Engel is, but he's a consultation liaison psychiatrist, so I had to give him a shout out, who really came up with this model. But hold on a second, we've moved to a biomedical model, but what about the psychosocial factors that are impacting health outcomes, impacting quality of life, and impacting access to care? So really trying to bring that back into the house of medicine, so to speak. Now, within this time, there's been a shift of various terms, and I know people in the room here and others more internationally have really grappled with, what do we call this area that we're living in? Is this medical psychiatry, behavioral health, integrated care, psychosomatic medicine? I cringe at that one at times, of the connotations of that in terms of mind-body, consultation liaison. And so there's much literature, much growth, which is, I think, hurt us in terms of defining competencies and care models. So here's a trajectory in psychiatry in looking at this interface that, thinking about med psych units, the first psychosomatic units were funded by the Rockefeller Foundation at Mass General, Duke in Colorado in 1935, thinking about this interface. There are a couple of societies that formed that brought together kind of medical professionals, psychiatric, psychology, internal medicine, family medicine. There are fellowships that were emerged as a result of this. There's a subspecialty south of the border that deals at the medical psychiatry interface, and there's more than 35 now, I think, at this time. And we looked at training opportunities, and there's been a shift from completely in an inpatient setting to looking at least a quarter of the time in most programs going into more an integrated type of model in outpatient practice. And I think this is in response to, as Paul alluded to and covered in many of his studies there, the high rates of mental health conditions in our medical and surgical patient populations, the comorbidity in patients with severe mental illness, and this recognition that medical conditions, their outcomes are significantly worsened by psychiatric conditions. So we talked about depression and cardiac disease. We know about depression and glycemic control. We know about adherence issues. We know about mortality as well being an end outcome. And so all of these kind of resonate in terms of how we're going to train delivery models or change delivery models and how we're going to train our future healthcare professionals. I think within that, and those of you who were here yesterday, were able to hear about new training models that are emerging more locally that have been built on national and international initiatives. So telemedicine and the use of technology. People heard about Project Echo yesterday as in the discussion, which is out of Echo Pain, and now we have an Echo Mental Health opportunity to use telemedicine to teach and train people that came out of New Mexico in the United States. There's an increasing move for co-location and collaboration. Again, there is psychiatric care for patients with non-psychiatric setting, and I will talk about reverse shared care, where as well, where in mental health settings you bring in medical specialists to to treat patients in psychiatric settings. There's duly trained or double board certified specialists, which again are south of the border in terms of having psychiatry and internal medicine, or neurology and psychiatry, family medicine and psychiatry. And then collaborative care models, or you could call it integrated care models, where you're now trying to train care coordinators to be that liaison or link between, in terms of patient coordination and care, but also linking between psychiatrists and primary care or other medical specialists. So here's one document. This is Shared Care, which I will term Integrated Care 1.0. And it was an initiative by the Canadian Psychiatric Association and the College of Family Physicians in Canada to look at kind of shared mental health care. And so this came out in 2000, really seeing that we need one system. So again, this is the kind of issue that's been raised here and what the MPA is trying to address. There's a focus on an interdisciplinary model of care, but I think there was some, the last page of this document actually has some important points here. So while it's encouraging to find the need for greater collaboration, there's a number of problems that remain. Primary care, you can insert any other medical specialty as well in there, and mental health care planning processes have occurred in parallel but at a systems level with little integration. And so my goal here is to highlight the need for an integrated approach for training, as well as we're starting to enhance integrated models of care through the MPA. And again, we see internationally new models of integrated care, and this is Integrated Care 2.0. Many of these models have emerged from the United States, and have proliferated internationally. So team care, the late Wayne Caton was one of the leads for that, and really exemplified better depression care and how it impacted better diabetes and cardiac care. There's a Diamond study in Minnesota, which used a large database to track patients in terms of depression management. Jürgen Unitzer and his study in impact, and even the Kennedy Forum came up with a document talking about all of these models in terms of improving behavioral care in America. And I think the key components, and I hope this will inform your discussions in the first breakout, is that there was a multi-professional approach. So there are care managers or care coordinators, and you can argue, that requires resources, but I think it speaks to the skill set of care coordination. There was knowledge and use of kind of step care pathways and how that was disseminated across the healthcare team. There was systematic screening and scheduled follow-ups. And then as we have one of the breakouts here talking about interprofessional collaboration, it was a key component in terms of these programs. And what's interesting with these programs is all of these programs, as they emerge, have started to develop their own training programs. And if you look at, we have a group here within the MPA that's going to be looking at this, about what we could deliver here in Ontario in terms of collaborative integrated care training, is that many of them have the same common themes. Some of them use a blended model of care, of teaching, some strictly online, and many have used more kind of traditional education basis. None have looked at simulation, and Sean provided an excellent talk yesterday about how simulation and interprofessional care could be used within the field of medical psychiatry. And many of you have seen this article, which came out of JAMA Internal Medicine in 2013, really highlighting the need to shift the healthcare professional or clinician of the 21st century. We've, traditionally been in that biomedical quadrant, but really looking at systems improvement. And I talked about in the previous slide that integrated care is about system improvement, measuring and improving patient outcomes. And also, I think our Wilson Center colleagues would be pleased to see this patient encounter skills and reasoning when evidence is inadequate or incorrect, and how adaptive expertise, which Maria, I'm sure can talk a fair bit about, is important in terms of developing that skill set and a competency in our learners. And again, the Lancet Commission also echoed this. Again, the changing demographics, the term I always hear is a silver tsunami, for example, and aging population, but also that there's a need for, with complexity, this pull towards subspecialization And again, how does that fit within our larger healthcare system? And again, we've already heard about technological innovation being a huge driver. And again, there's this huge crisis in terms of how our curricula are being delivered, the fragmentation, and how we have not taken advantage of these new technologies in our current training. And again, throughout the day, I'm hopeful as our plenary, as Hirsch is going to talk about it, is how we might be able to address some of these through new models of learning and teaching. So, the Medical Psychiatry Alliance is looking not only at how we can integrate across healthcare professions and specialties and disciplines, but also integrate across the continuum. I think one of the foci of the MPA has been undergraduate medical education, but it is looking at postgraduate and also, as I mentioned, continuing professional development and practice. And again, how can we do this in an interprofessional way? Because many of these models have relied on and showed best evidence with interprofessional competencies in care. And so, again, we don't have to reinvent the wheel for competencies. There's many competencies out there for integrated care. Now, probably about at least 5 major documents, and here's one, again, by SAMHSA that looked at core competencies for integrated care: interprofessional communication, collaboration and teamwork, screening and assessment, again, care planning. You're seeing these common themes come up: intervention, and that's the content area of both medical intervention as well as psychosocial interventions. Cultural competence and adaptation, again, thinking about diversity and how we are able to attend to that to the individual patient and family. A systems-oriented approach, again, thinking about how we can think about big data to inform this, using quality improvement in informatics to guide our patient care. So the APA, the American Psychiatric Association, is also, they allowed me to show this slide, a report in 2016, which is going to look, again, across the continuum, integrated care training, highlighting many of these. They made me put that disclaimer on there because that was the only way I could show this slide or any slide related to this document. But really, it will be looking at undergraduate training, looking at postgraduate training, and continuing education. And they've articulated a few milestones as well as a few competencies in this document. Again, this is in psychiatry, and I think where the MPA can really take advantage of this is to expand this across disciplines to have a more holistic approach. Here's one graph from this particular document. It came out of this particular study where psychiatry directors went back to their medical schools to see where behavioral or mental health education was occurring, which I think is interesting. So doctoring, it would be like kind of interviewing, clinical skills, kind of, and so you expect that you're going to, in communication training, you should have some behavioral health in there, right? So that's not surprising. But I think as you look in neurology, reproduction, you also have high levels of behavioral health training, but as you move further down, you see less and less. And so, as you're thinking about today, I want you to reflect on how we might be able to make this graph look more level in terms of training. This starts in undergraduate, but I suspect if we moved into postgraduate, we would see similar patterns. And then in clinical rotations, again, family medicine and pediatrics very high, obstetrics. But again, as we get further down, we're starting to decrease. And this is from the United States. And again, interested to hear people's experiences and thoughts, both locally and here in Canada. And I think we know that there's been increasing focus, I know, within psychiatry and mental health training to look at more preventative and primary care for patients with mental illness, looking at integrated care models. And the Royal College has mandated now training for psychiatry residents in collaborative care, and so that's part of the core training. And we see, and having, as I was preparing for this presentation, asking colleagues in pediatrics, family medicine, and internal medicine about mental health training, there has been an increase in awareness of integrating this throughout more locally, but we still have a lot to do. And so we still have an absence of kind of dual training in terms of some of those more complex situations that require expertise. And one of the recognitions, family medicine is historically had a high level of mental health training, but how can we spread this more broadly? So I think one of the mandates for continuing education, we're talking about medical students and residency now, continuing education, that we need to continue to expand our understanding of these new models of care and lifelong learning in these areas, continue to update knowledge base and skill sets as we have more evidence about, for example, depression and cardiac disease as a risk factor, and how we can better manage those co-occurring conditions is important throughout practice. And then training healthcare professionals in practice of treating to target, and that requires defining it internally within mental health, but also transmitting that more externally to all our care partners, and improving skills in leadership and team building throughout. So I think if you think of interprofessionalism, we can think about as practice models change, that there's key components of interprofessional collaboration that also need to change, which are shared expertise needs to increase, right? There was an interesting topic or comment by Andrea Furlong yesterday, who was talking about the echo pain model and the resistance in her colleagues yesterday, who, so this is a model where the goal is to transmit expertise to primary care, especially in rural parts of Ontario. And she talked about the need to be able to collaborate, learn from one another, but more importantly, feel vulnerable enough to share your knowledge and impart it on someone to make them an expertise and you less of a specialist. And she said that notion was rejected by some of her colleagues, and they had difficulty with that notion of losing their specialist identity, right? And I think these are some of the things that to consider as part of a shared expertise type of model. And this notion of professional autonomy decreases in that we're not working in silos, but that the collective expertise of the team in these interprofessional care settings can address chronicity, complexity, and improve access to care. So I think the Medical Psychiatry Alliance is an opportunity for education and innovation and integrated care, about bringing together, and this is why we're here today, about how we can start teaching in undergraduate education. And we're going to hear a bit about longitudinal integrated clerkships as a model, but there are many more opportunities starting in kind of pre-clerkship foundational years, what we can do in residency programs to bring together learners from different areas and specialties, and what we can do in practice. Many of us go to our national conferences, but how we can cross-pollinate and continue to train both locally and use innovative models of care. Again, Sean's illustration of how interprofessional simulation could be a model for that is an interesting idea. So again, we have these two physical and mental health domains, and I think the goal here is to look at this combination and where we can play in this common sphere about developing a more integrated approach to education. And so I'm hoping that this provides a high-level context for our discussions today. I'm hopeful that we can come up with some shared understanding of where and what we need to teach our learners across the continuum. And I'm hopeful by the end of the day that we're going to have some very creative ideas in how we can move forward through using the MPA as a vehicle to actualize these new models of training. So thank you very much. And so I will take, I think we'll come up for questions here. Yeah.